So we're gonna make this smooth transition from wellness to alcohol withdrawal. This is the EKG Pharm Rads lecture, so I'm mostly gonna try to focus on the treatment of alcohol withdrawal. Of course, we get a ton of patients in the ED with alcohol use disorder and withdrawal symptoms. So this might be a little bit of review for a lot of you, but I wanna include some things around some of the medications that we don't commonly use in the ED that we might want to consider a little bit more. I want to thank the EKG Pharm Rads team, especially Dr. Tang. He sent me a lot of useful resources. So first I want to talk about the general pathophysiology of alcohol withdrawal, as understanding it is super important to understanding the therapies that are useful. I'll review the clinical manifestations and evaluation of patients in withdrawal, the general approach to assessing these patients and some specific considerations to keep in mind. And finally, I'll go over the therapies that we have at our disposal, things like benzos, there's also Phenobarb, and of course, Robbie, I will talk about ketamine. So first, a really simplified pathophysiology of ethanol. Acutely, alcohol potentiates the effect of GABA and antagonizes glutamate at NMDA receptors, which leads to overall inhibitory effects of alcohol. But chronically, alcohol use will lead to conformational changes of the GABA receptors, leading to desensitization and an upregulation in the number of NMDA receptors. So when you get a sudden cessation of alcohol use in these chronic alcoholic patients, you'll get with the downregulated GABA and the upregulated NMDA, you'll get CNS hyperexcitation, which is the basis of alcohol withdrawal syndrome. And in some very long-term alcohol use, especially with patients with repeated episodes of withdrawal, it can actually lead to permanent alterations of the GABA receptors in a phenomena called kindling. And these patients' episodes become increasingly difficult to treat and may even become resistant to benzodiazepines completely. And these are maybe the patients that we should consider other therapies such as phenobarbital. So I'll briefly go over the general presentation. I know you guys have seen this 100 times. Of course, there's the timeline in which we expect certain phases of alcohol withdrawal syndrome to present depending on when their last drink was. First, within the first few hours after the last drink, you get the general tremors, the anxiety, you'll get the hyperadrenergic hyperactivity, such as diaphoresis, tachycardia, hypertension, and hyperthermia. Then within the first 12 to 24 hours, the patients may develop alcohol hallucinosis. Unlike DTs, these patients have a normal sensorium, but they might start experiencing tactile or auditory hallucinations. Then also within the first day or two of cessation, some patients may have seizures. They generally present similar to GTCs, but they tend to be isolated. They tend to actually be shorter than epileptic seizures, and they actually tend to have a little shorter post-ictal periods. And these patients, about a third of them will progress into delirium tremens, a phenomena that actually Oliver Sacks wrote about in a great piece he wrote for the New Yorker called Altered States. And basically we expect DTs within the first few days and up to a week after alcohol cessation. And as Oliver Sacks described it, it's a bizarre perceptual disorder with altered sensorium. And to actually make the diagnosis, they have to have autonomic instability with it. So in the ED, you see a patient with alcohol use disorder and you're concerned that they're going into withdrawals. First, you want to get your history, of course, establish a timeline from their last drink. You want to characterize their own personal history of withdrawal, if they've had seizures before, if they've gone into DTs, because this might help you risk stratify some of your patients. Then, of course, you examine your patients, especially the ones who are, with all your alcoholics, we should really undress them and do a thorough exam. You're looking for things like the hyperadrenergic state, the autonomic instability, and all the other signs of alcohol withdrawal. And in patients with more severe symptoms that you anticipate possibly admitting, of course, you want to assess for any metabolic derangements, which are very common in some of these patients. And it's important, especially with these patients, not to anchor. A lot of these patients might have other causes of their symptoms or might have concurrent illnesses that need to be addressed. I think a lot of us have that story of that alcoholic that we got burned before. For me, I had a patient on the floor who came in with severe alcohol withdrawal, ended up going into DTs. They developed refeeding syndrome, They're also COVID positive. And Thanksgiving of last year, I spent resuscitating them. They went into florid ARDS, ended up intubated on multiple pressors in the ICU. So always keep a wide differential. Alcohol withdrawal can mimic other toxins. You don't want to miss any intracranial causes, especially like trauma. A lot of these patients have high risk for subdurals, encephalitis. Consider other causes of delirium like sepsis. And don't forget that these patients are prone to sometimes very significant electrolyte derangements like hypoglycemia, alcoholic ketoacidosis, severe hyponatremia, or other significant abnormalities and things like refeeding syndrome. And there are a couple of scoring systems that you can use. The one that you're probably most familiar with is the CWA score. I don't know if you guys have done it yet, especially interns, but it's pretty cumbersome and it's somewhat subjective, but it is kind of our, not gold standard, it's our standard way of assessing withdrawal patients. And if it's about 8, the score is 8 or less, that's generally our mild patients, the ones that we think about sending home. And then 9 to 19 is moderate and above 19 is severe. And the score goes up to 67. There was some EM literature that cited using the RAS score instead, which usually we use to assess the sedation of patients that are intubated, but just a little bit quicker and it's slightly more objective. There's also this other scoring tool I came across, the prediction of alcohol withdrawal severity score. And it's on MD Calc, and it's just based on 8 questions you can ask the patient, a blood alcohol level and their vital sign. And a score of 4 or higher actually puts a patient at very high risk of developing moderate to severe alcohol withdrawal syndrome. And the nuances of withdrawal management I'm going to discuss aren't necessarily going to pertain to our most mild patients, the ones that we can kind of just give some Librium and send them out. It's going to be more in relation to our more severe withdrawal patients that might be a bit harder to control or who have a high risk of developing severe or withdrawal or DTs. And when it comes to managing alcohol withdrawal, I think the first medication that comes to mind is benzos, right? However, before 1970s, the Phenobarb was the first line treatment for alcohol withdrawal. And it wasn't until benzos came out in the market in 1960s that we saw this transition from Phenobarb to benzos. But the transition actually wasn't driven by evidence, but really was just a marketing push by pharmaceutical companies to dominate over the use of barbiturates. So these are probably the most common benzos that you'll come across when you're treating withdrawal. You got your Versed, your Librium, your Ativan, and Valium. And there was a 2010 Cochrane review that reviewed the differences between different benzos. They didn't see an overall difference in outcomes between different benzos, but that doesn't mean that it doesn't matter what you choose, that you should really pick your benzo depending on the individual needs of your patient. So looking at these benzos, we know that Versed is very quick on, which is why we like it a lot in the ED. Ativan takes a little bit longer. Librium, of course, being a PO medication, takes a lot longer. But Valium actually, IV Valium, that actually works pretty quickly as well. And looking at the half-life, of course, we know Versed is quick on, quick off. Ativan, a little bit longer acting, but Valium actually has a much longer half-life. And all of them have active metabolites except for Ativan. So Librium we generally like for our milder symptoms if they don't need immediate control of their withdrawal symptoms. But in more severe patients, especially the ones we might anticipate admitting for withdrawal, I think we should start considering using Valium over Ativan more. I don't see it that commonly in the ED. I think previously it wasn't available in the Pyxis and there was like a nationwide shortage, but it is available now. And some of the considerations that I think make Valium a little bit better than Ativan is it's rapid on, it's longer lasting, and it has active metabolites. One of the downsides is you can't really give it IM. So if you really need to give something IM because you don't have an IV yet, Ativan is maybe a better choice. Though if you just really need to get them down to get a line and then you want to give Valium, you can also give maybe some Versed IM while you get that line. The only thing is also in severe liver disease, diazepam and Librium are both hepatically metabolized. So in these patients, you might want to stick more with the Ativan, or you can also use oxazepam, which I actually haven't seen much. I'm not really sure how available it is. And then other positive of using Valium over Ativan is because it's shorter onset, you can actually use escalating doses, maybe 5 to 10 minutes apart, whereas Ativan, you have to wait a little bit longer before you redose, like closer to 15 to 20 minutes. So the thing is, benzodiazepines only work on GABA receptors, and they actually depend on the presence of endogenous GABA molecules. However, we know that the underlying physiology of withdrawal is both downregulated GABA with upregulated NMDA activity, and barbiturates directly open GABA receptors, so don't actually depend on endogenous GABA, and they also act on the glutamate system. And when we talk about barbiturates in withdrawal, we're specifically talking about Phenobarb, which has a rapid onset, long half-life of 50 to 140 hours. And you can actually give it IM, IV, or PO, and all of them actually have about 100% bioavailability. One of the other positives of it is that because of its extremely long half-life, it will kind of auto taper itself, meaning that over the first day or two of treatment, you can give medications and dose to reach a therapeutic level. And then after that, it'll kind of taper on its own because of that long half-life. And the evidence I saw, there's a couple of non-inferiority trials comparing benzos and barbiturates. It shows that it's overall fairly equally safe, equally effective, but most didn't show much of a difference in overall outcomes, though some of them did show that if you use it as an adjunct, it might reduce your benzo dose required. And one study did find that it has a decreased rate of ICU admissions. So Phenobarb has a more predictable pharmacokinetic and pharmacodynamic profile with a more linear dose to drug level relationship. Another positive is that unlike benzos, you can actually measure the level of Phenobarb in the blood, which might help guide your management. I've never actually sent it, so I don't know how quickly it comes back though. And it does have a greater therapeutic index, and at more moderate doses that you would be using for withdrawal, it actually has less sedating effect compared to benzos. And benzos are also known to cause delirium, especially in critically ill patients. And sometimes the issues with treating withdrawal with benzos is that patients may develop this non-alcohol related delirium, which some might mistake for worsening withdrawal or DTs, but continuing with benzos might actually not even be treating it and might even worsen it. And theoretically, Phenobarb has a lower risk of causing this, but I didn't actually find a lot of evidence that proved that. And Phenobarb has been shown to decrease the dose of benzos you might require, so it might also decrease your risk of developing this delirium because of the benzos. So you can actually use Phenobarb as either monotherapy or as an adjunctive therapy to benzodiazepines. The patients that you might want to consider going straight to Phenobarb are the patients with very significant withdrawal history who have this kind of kindling phenomena that I talked about earlier and are known to have benzodiazepine resistant withdrawals. On the floors, once I actually had a patient admitted to me with withdrawals who the last time he was admitted to the hospital depleted the hospital source supply of diazepam and ended up in the ICU on a Phenobarb drip. If you use it as a monotherapy, you want to load them with 10 milligrams per kilogram, and then you can start giving 130 milligram boluses every 30 minutes as needed to control their symptoms. But you might also want to consider transitioning patients to Phenobarb if you started them on benzos, if they still aren't controlled after, in the literature, they state over 200 milligrams of diazepam or 40 milligrams of lorazepam within 3 hours. And in these patients, you don't load them. I know there's a concern that with the benzos and the Phenobarb, there's a risk of toxicity, but you really are only giving them these like 130 milligram boluses, which is a much smaller dose than the 10 milligram per kilogram loading dose. And usually our toxicity levels, we think are about 40 milligrams per kilogram for the Phenobarb. So by really giving these small boluses, you shouldn't get to that toxic level so much. This is a guideline I found online, kind of going over some of the things I already talked about. There is actually a PO Phenobarb paper that we can continue. And most of the literature does say max out your dosing for your patient to 20 to 30 milligrams per kilogram. So that way you kind of avoid that 40 milligram per kilogram toxic dose. The patients that unfortunately we might not be able to use Phenobarb for are the patients where you're not completely clear about the withdrawal diagnosis because it is so long acting. If you're not sure that it is absolutely withdrawal, then Phenobarb probably isn't going to be your drug of choice. There are some significant drug interactions, including with HIV medications. So you might want to consider a different therapy if they are on those. You can't unfortunately use them in advanced cirrhosis or ESRD or in pregnant patients or acute intermittent porphyria. And if they are on chronic Phenobarb for seizure disorder, they might actually already be therapeutic. So giving them Phenobarb as withdrawal therapy might not actually be helpful and might have a high risk of toxicity. And whether you choose to go with the RAS or the CWA scoring scale for your withdrawal patients, it's important to do serial assessments. And you really can redose benzos and Phenobarb as needed. You really want to get their symptoms under control within our ED evaluation. And I'll talk a little bit about more of that later. Another medication that has come up a lot in the literature is ketamine. So it is an NMDA antagonist. So theoretically, it works as an adjunct to GABAergic agents like benzos. And the great thing is it doesn't suppress respiratory drive. It works pretty immediately. It has a rapid onset, short half-life, and it may be effective against seizures as well. Unfortunately, there's only been about 3 retrospective uncontrolled studies, but though all 3 of them did show that they're effective in reducing benzo requirements. So there's not a ton of great evidence to support their use yet, but physiologically it makes a lot of sense. And the dose that at least 2 of the 3 studies used is 0.2 milligrams per kilogram per hour, which, as you know, is much lower than the 1 to 2 milligram per kilogram that we use for sedation or the dissociative dose. If you're going to end up intubating the patient, probably the best sedation to go with is propofol. And then there are some other adjuncts that I kind of put them all in one slide, so it tells you how useful I think they are, but they did come up in a lot of the literature I came across, so I thought it was at least worth mentioning. First, there is Precedex. It should only be used as an adjunct. It can help attenuate the symptoms, but doesn't actually address any of the underlying physiology. I also saw beta blockers and alpha agonists like clonidine on it. Again, can help attenuate symptoms, but doesn't actually treat the withdrawal and may even mask the severity. Anti-epileptics in withdrawal seizures, there's really insufficient data to support routine use of it. I mean, if you want to give Keppra, it's fairly safe. Gabapentin I also saw come up, but mostly as in the outpatient setting and really more for mild withdrawal symptoms. Baclofen also came up a lot, but it seems like the evidence for its use isn't there either. And antipsychotics may actually lower your seizure threshold, so might actually have more harm than benefit. So one potential algorithm I came across in the literature is if you have a patient with severe withdrawal or you're concerned that they have a risk of going into severe withdrawal, you can either start with benzos, you can go straight to Phenobarb if that patient has a history or you're concerned that they might have a benzodiazepine resistance. So you start with either Valium or Ativan, whatever your choice is. If you notice you're reaching doses of over 200 milligrams of the Valium or over 40 milligrams of Ativan in 3 hours, this is the point where maybe you should consider adding Phenobarb. Of course, if they're intubated, you want to start them on propofol. And if you want to add an adjunct to Phenobarb and they're not intubated, you could consider adding either ketamine or Precedex. There's no evidence to choose one over the other, but physiologically, ketamine kind of makes more sense because it actually addresses some of the underlying issues. But just some things to consider about our withdrawal patients, the ones that we're going to admit. Of course, our IM colleagues, they're all familiar with benzos. They use them all the time. That's what they're gonna be more comfortable with. And I've had this experience on the floor when a patient got Phenobarb in the ED, that they don't really know what to do with it. And they're really scared about combining benzos and Phenobarb. I doubt we could give IV Phenobarb on the floors. We could theoretically give PO, but it might be something that the medicine team is not super comfortable continuing. And of course, ketamine is not going to happen on the floors, even in the step down unit. So I think it's important that we actually stabilize these patients, or at least control their symptoms before we admit them. If they're going to medicine, likely some resident on the 7th floor is going to put some order in for a Librium taper and 2 milligrams IV Ativan PRN, right? That's not really going to control some of our severe patients. So you really want to like tie them up nicely, get, load them with benzos, load them with whatever they need before you like kind of hand them off, because otherwise their care isn't going to be as quite robust. So finally, just with these patients, always keep a wide differential. Don't get burned. Don't have that story about that alcoholic that you feel like you messed up or missed something on. I think Valium is actually a fairly good choice over Ativan, especially if you're planning on admitting these patients. And if they aren't responding to benzos, I think we should really start considering transitioning to Phenobarb. And while these adjuncts like Phenobarb and ketamine can be useful, unfortunately in our hospital system, it might kind of change their disposition, because I think these patients might end up going to the ICU just by the fact that floor medicine doctors aren't gonna really continue that therapy or not feel comfortable continuing that therapy. And that's it.
Just some comments. Yeah, definitely when I started training, Valium was available, so that's how I was trained to give it. And obviously we have a national shortage, so a lot of our residents aren't as skilled or as comfortable using it, but I think we should be giving it. I think it's fairly recognized that there's benefits to giving it over the recent handful of years. I've started to incorporate Phenobarb into my practice. I had not been trained really to give it, and so it took a little bit of research and reading and talking to a lot of my colleagues in other institutions where there's more of a culture of giving it. But practically speaking, like, how do I incorporate it? I still do my doubling escalating doses of diazepam. Usually I can't get up to 200 milligrams in the ED, because by the time I'm ordering 80 or more, it has to come from pharmacy. A lot of times I burn through all of our Texas supplies, so that's usually out. And in the past, that's when if it just seemed like the patient's getting worse, it's getting harder and harder for me to get 160 milligrams of larger doses of Valium. I have to just intubate it. So now, after I've given my 10, my 20, and then my 40, I order for my 80, and while I'm waiting for the 80, that's now when I've been ordering my 130 of Phenobarb and start to give it there and use it as an adjunct. Because usually by the time I order my 80, there's going to be a bigger time delay in taking the medication with the patient. And that's not, you kind of see the data that I mentioned, that just not saying that that's a protocol anywhere that I got, but just talking to a lot of other people who are more comfortable around the country using it, even as monotherapy, which I'm not therapy myself. I've been doing that, and I haven't seen any major adverse effects of doing that. Sometimes you can see hypotension with Phenobarb, but a lot of times these patients, their autonomic instability is pretty high. That's why I'm giving them high doses, and so their blood pressure is pretty high. And I haven't had any really negative things to say about adding it that way, and may or may not have saved off intubating patients involved myself some time.
There actually is a protocol with pretty much exactly that development that starts with like 10 IV Valium that will do that for
Yeah, Denver has a couple protocols that I got from Dr. Tang as well.